Welcome to Global Healthcast, brought to you by Global Health Press. In this podcast series, almost once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. I am Joe Schmitt, and with me is Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt, and good morning, good afternoon, or good evening to those who are watching or listening to us.
Thanks for joining us, and that are our topics today. Severe acute respiratory distress syndrome is related to COVID and can damage heart even when SARS-CoV-2 does not affect heart tissue. And how that works, Melvin will explain. He will also show you that a new cancer therapy sees brain tumor almost disappear in 5 days. Very promising, and you will learn more in a minute. And I go on with my series on types of side effects of vaccines. And today I cover COVID and COVID vaccines and myocarditis. Let's start. And Melvin, what is the story with respiratory distress syndrome? And, as a result of COVID, but not really related with COVID. This is funny.
Yeah, so this is actually showing us that severe acute respiratory distress syndrome related to COVID infection can happen, can damage the heart, even when SARS-CoV-2 itself does not affect the heart tissue. And this finding came from a study published in Circulation, and the study suggests that ARDS triggers widespread inflammation in the body, which leads to secondary cardiovascular complications. Um, and this is really important because if you remember, we have been talking about how SARS-CoV-2 can affect different uh, organs of the body, and clinicians and researchers have observed for 4 years now that COVID-19 infections can lead to an increased risk of stroke, increased risk of heart attack and inflammation in the chest, but the mechanism of damage was not really understood. And the research also suggests that suppressing inflammation through treatments might help minimize these complications. And so I think this is really uh, an important piece of information that adds to what we already know about COVID.
So in the end, there is an underlying mechanism, and once you have ARDS, acute respiratory distress syndrome, that may be a result of the severity of the disease. You have ischemia or whatever it is that results from the situation and not from the virus. Is that a
Yes,
correct interpretation? So
yes,
there is
that
no
is the
viral
case. Yeah.
infiltration of the myocardium. The virus doesn't infiltrate heart cells and then kills heart cells, but it's a secondary effect of the infection.
I think it can actually happen both ways, but the study itself just shows us that it does not have to be in the cells. It can be just like what you explained, inflammation and surrounding damage to the tissues that would cause this kind of basically this cardiomyopathy through inflammatory
Okay.
responses. Yeah.
Yeah. I mean, they have that in the conclusion here, and we will put this in the show notes so you can read the whole article or the conclusions. Yeah, it's a very interesting concept.
Hmm.
So, yeah, thanks for bringing this up. So, we learn about COVID every week, right? It's always something new, very interesting. Yeah.
Yes, that's right.
And your second story is as interesting. It is not an infectious disease to the best of my knowledge, but here glioblastoma disappeared with some new
Hmm.
treatment.
Yes. So, well, I think this is really interesting, even if it's not infectious diseases. I think it's something that's interesting for public health globally. Scientists in the US have reported cases of three patients with glioblastoma. It's a common and aggressive form of brain cancer. They were successfully treated using a pioneering therapy, and a team at the Massachusetts General Hospital in the US treated the patients using CAR T therapy. It's a type of personalized therapy that uses the patient's own immune system to target the cancer. So basically, the T cells are extracted before scientists make changes to them and gradually drip them back into the bloodstream of the patient. They are then able to recognize and attack the cancer cells. And in this particular study, the three people in the clinical trial were treated with this CAR V3 Team E T cells, which is a variant of the existing CAR T therapy. Basically, they just added additional antibodies before infusing the T cells back into the patient. And during the trial, the patients experienced dramatic reductions in their tumor size after a single treatment, as you can see in this radiograph here.
Very, very, very promising. Here, I guess to put this in perspective, Melvin, for a clinical trial with a new vaccine or with a new therapy, you need thousands of subjects to show versus a non-treated group versus a placebo group that there is a benefit, right? So
right.
Here in this case, glioblastoma, if untreated, you will die in the end, right? It may take some time depending on age and I don't know what, on the type of tumor, whatever, but you will die. And here that you see within a short period of time that the tumor disappears. I think with 3 patients, if I had the diagnosis, I would like to be number 4. And this is very convincing. Like if you have a treatment for rabies, rabies is 100% deadly disease. If you save 1 patient, the diagnosis may have been wrong or whatever happened, nobody knows, but he didn't have rabies, right? But if you have 3 consecutive patients with rabies and they survive and are back to normal, that is enough. You don't need number 4. So this is very exciting because the effect is so impressive. If I look at the pictures here, it is very, very impressive.
Yeah, that's right.
Yeah. New hope for cancer patients, CAR therapy. Very nice.
I think the issue with CAR therapy at the moment is just it's very expensive.
Yeah. And there are few centers who can do it, right? It is experimental, but it's difficult to do. Yeah.
But I would imagine, like other technologies in the past, it will become cheaper as advances are happening in the field.
That will be the next big blockbuster around the globe. If it will be, it's very individualized, I guess. So I'm not sure if it will be a blockbuster, but it will be a very new way to approach, particularly cancers.
Yeah, that's right.
So I already had moved to the next one. And as you remember, I started with types of side effects of vaccines. And you remember, we had as side effects of vaccines, local reactions and systemic reactions like fever, malaise, and local reactions would be swelling and redness. We had anaphylactic shock, very rare, 1 to 500,000 as a rule of thumb. We had technical errors. If you mix up the vaccine that is supposed to be injected, that would be an example for that. There are others. And then what people worry about is certainly vaccine-specific side effects. And that would be, for example, if you inject the tuberculosis vaccine to a patient with a T-cell defect, the live vaccine would disseminate throughout the body and may kill the patient. So that would be a vaccine-specific side effect. Now, we are covering the SARS-CoV-2 vaccines, and I covered in the past facial paralysis, and the conclusion was, yes, COVID vaccination does cause facial paralysis, but the incidence is less with vaccination as compared to natural disease. So if you worry about facial paralysis, get the vaccine because it's much higher with the disease than with the vaccine. And it is a little bit similar with vaccine-induced thrombocytopenia and thrombosis, VITT, which is only associated with the vector COVID vaccines. And today I will cover myocarditis. So what is myocarditis? What you feel as a patient is chest pain or chest pressure, or you see respiratory dependent differences in your chest. You may have shortness of breath. You may have palpitations. You may not feel well. You may be very weak and fatigued. And you may have subfebrile low-grade temperatures or frank open high temperatures. And then you have different signs. If you go to your doctor, he will have additional findings like a C-reactive protein that may be elevated. He may find a pericardial effusion in the heart, and he may find other signs that are going along with myocarditis. And myocarditis means nothing but there is inflammation in your heart. So basically, the question is, does COVID vaccination, do COVID vaccines induce inflammation of the heart? And this is the proposed mechanism. You have here the virus or you have the vaccine. And both have the spike antigen. This top antigen, this part here is what the vaccine is directed against. Actually, the vaccine represents or is this protein. And the natural virus certainly has many of these proteins. So the mRNA vaccine is packaged into, the mRNA is packaged into lipid nanoparticles. And here the adenoviral vectors, they have the DNA in here. And that is then induced in a human being. And the proposed mechanism is that antibodies that are produced as a result of vaccination cross-react with receptors of the heart. And that's when you see myocarditis. So the vaccine induces inflammation. An antibody response that always goes along with some inflammation. And in this case, the inflammation results in an inflammation in the heart called myocarditis. Protective factors may be estrogens, so particularly women may have less, and testosterone, the male hormones, they may increase the effects of vaccination. And here you see a little bit more of the immune mechanisms. I don't go into this. The important point is both the virus as well as the vaccine have the same spike protein. And apparently the spike protein is important because it may cross-react with antigens or with partial structures in the heart. Now, what are the data? This is from one study from Israel, where a large cohort of vaccinated subjects, more than 800,000, were vaccinated with various vaccines. And what you see here, after dose 2, myocarditis is highest in male young subjects aged 12 to 15, 16, 17, 18, 24, 25, 49. So this is per million doses after mRNA vaccines in the first week, highest in 16 to 17-year-old male subjects after dose 2. It is less frequent with a booster dose, but still you see the bolded numbers here, still relevant in the respective age groups of males, but it probably plays no role in females' first dose and a very little role in females with dose 2 and not in the booster. So this is, I think, the best data because it's population-based, and so you don't miss much. You get them all, and in the system, every case is captured. So I think this is really among the best data that we have out there. Now, how do vaccines compare there? And here I have by age and gender, hospitalizations prevented with a vaccine, and then the excess cases. I think this is important. So if you look at all patients, male or female, 18 to 39 years old, the vaccine prevents almost 3,000 cases of hospitalization, but it may cause 33 myocarditis cases. So this is a 100-fold difference, right? So if you worry about COVID, still get the vaccine, even if there is a somewhat elevated risk of myocarditis. If you take the Pfizer vaccine, it is somewhat less, the hospitalizations. So the efficacy of the vaccine is roughly the same. The excess myocarditis are a little bit less with the Pfizer vaccine. If you go down to males, you still have a lot of cases prevented, and you get a little bit more cases with the Moderna vaccine as compared to the Pfizer vaccine. I think this is very interesting data. So the risk benefit really favors vaccination, although this is all hospitalizations, and this is myocarditis specific. Now let's look a little bit more into other diseases from the same data set from Israel. Again, more than 800,000 subjects. Blue is the incidence with, or the risk ratio to be precise, the risk ratio of vaccination in blue versus the disease in orange. So acute kidney injury, you are protected if you are vaccinated. It is less than 1, which means it is reduced. If you have COVID, it is elevated. Appendicitis, it is about the same, no significant difference. Arrhythmia from the heart, if you have myocarditis or what else, it is more frequent in the natural disease versus the vaccine. Deep vein thrombosis, same thing, much higher in the natural disease. Zoster, very low risk with both. Intracranial hemorrhage, and we spoke about deep vein, we spoke about VITT before. Again, it is prevented by vaccination. So if you worry about intracranial hemorrhage, get the vaccine. Lymphadenopathy, which means lymph node swelling, you see more if you're vaccinated, which is normal. That's what you expect. You get the vaccine, and if you get it in the left arm, you will feel your lymph nodes under the arm. That's where the immune response is generated. So this is something that you even want to see with it. Myocardial infarction is more with a disease, less with vaccination, significant difference. Myocarditis overlaps. What you see here, it is still more frequent with the disease as compared to the vaccination, but there is no significant difference here in this graph. Similar with pericarditis and pulmonary embolism, if anything, vaccination would protect again. What is the summary of all of that? Let's look at myocarditis per 1 million subjects. If you're not vaccinated and you have COVID-19, then your risk to get a myocarditis for 1 million subjects is 1,000, I would say 400. With vaccination, it is down below here. It is probably less than 100. Smallpox vaccine is much less. Background in the hospital is a little bit less. You see, there is not much difference here. Background in the hospital means no COVID excluded, no vaccination. And then you see myocarditis, this is the frequency. So versus vaccination has a higher rate, but it's not that much higher overall. And if you look in the general population, certainly, then you see that this is comparatively very, very low. The diagnosis is established by clinical examination history, by additional tests, including imaging. The therapy today is immunosuppressive therapy, and that is listed here in general. In summary, the highest incidence of myocarditis occurs in young men after the second dose, and it is roughly 100 cases per million. The incidence of myocarditis, if you have COVID-15, is 1,500 per million, so 15 times higher. The diagnosis is established by various factors, including CMR and EMB, and finally, it is a treatable disease. And that brings me to the summary of our side effects of COVID vaccines. Again, it's facial paralysis, causal relation, but if you worry about it, get the vaccine, because the vaccine protects you from the disease-induced facial paralysis. The ITT, thrombocytopenia and thrombosis, is caused by the adenovector COVID vaccines, and that, again, is something that is very, very rare, and that is something in many countries, the adenovirus vector vaccine is largely not used. And finally, myocarditis, like with facial paralysis, there's causal relation, but if you worry about it, get the vaccine, because it's 15 times less frequent with the vaccine as compared to COVID-19. And I think, Melvin, you have any questions to myocarditis and any other side effect of COVID vaccines and vaccination?
No, I specifically like the data from Israel and how they presented it. I think it's very clear, and with that kind of data, you can be assured that getting the vaccine is really the right choice for you.
Yeah. The one thing that I wonder is, if you are in a court and you are the judge, and a patient with myocarditis or facial paralysis claims that he was damaged by the vaccine and he wants to have compensation according to your national law, would you grant him compensation, or would you say, look, if you had come down with COVID, it would be 50 times higher? Any idea how you would decide?
Well, I think that's a good thing because I'm not a judge. I don't know what to say.
Yeah. Look,
And yeah,
yeah, for the safety of vaccines, I would grant them the compensation, because those who really said, I get the vaccine, I do the right thing for public health, I protect my environment, I take the vaccine. And in the end, there is a little excess number of cases from vaccination. So why not give them the compensation? Because they were willing to get vaccinated and they did get the shot. And everybody else came down with facial paralysis and myocarditis because they did not get the shot. And they really caused a lot of trouble and cost in the healthcare systems. But clearly that they get no compensation, right? They could have been vaccinated. So I would grant compensation, but I'm not a judge like you, and I don't envy those who need to make decisions here, right?
mhm.
Yeah. Very good. So let's summarize. I think we had very interesting topics today, and we know now that acute respiratory distress syndrome may be related to COVID or is related to COVID, and it can damage the heart, even though the virus doesn't damage the heart. Very interesting. It comes from the general inflammation of the body and from other mechanisms that Melvin pointed out. And Melvin showed you that there is a new treatment using T cells, and they killed this brain tumor in a few days. This is amazing news, and this is one of the first reports on that, and CAR therapy, that keep in mind that will be very frequently covered by the media in the future. I covered side effects of vaccines, and most importantly, facial paralysis and myocarditis is reduced by vaccination, but at the same time, at a much lower frequency. These vaccines, COVID vaccines, may induce facial paralysis and myocarditis, but at a log-fold lower frequency than the natural disease. And again, which we spoke about before, so this is a different story. Having said this, Melvin, at the end of our session today, any last minute, any last word?
No, I think we are learning more and more about COVID every day, even though this is technically 4 years or more now. And I assume that we will still be learning more about COVID in the next 5 or 10 years.
Yeah, more to come. And I'm very happy that we had our podcast today. Join us and like us if you liked our blog this time. And I'm happy to see you again very soon. I am Joe Schmitt, and with me was Melvin Sanicas. Goodbye, Melvin.
Thank you, everyone. Stay safe.